Video, I'm going to go over renal function again, and I'm going to go over acute kidney injury, chronic kidney injury, or chronic kidney disease, I should say, and then AKI and CKD signs and symptoms. Then we're going to go over dialysis. So this is a big unit. This is going to be an exam with a lot of content on it, so I don't want you to wait until the last minute to start studying. I'm going to kind of condense this information by teaching like signs and symptoms together. For example, I'm going to go over how the kidney is supposed to function and then what happens if it can't do that function, because we can apply that to a lot of different diseases, okay? All right. So the first kidney, I'm going to talk about a wet bed. Sorry, it's a mnemonic. And the first letter is A for acid-base balance. So this is a kidney function that the kidney normally does for us. So your findings, if the kidney can no longer regulate the acid-base balance, your patient is going to be in metabolic acidosis, and they will have Kussmaul's breathing. So that means they'll have a low pH and a low bicarb. The treatment for that is going to be fix the kidney if you can. With chronic kidney disease, sometimes you're not going to be able to fix that kidney, but in acute kidney injury, hopefully they'll get better. And then dialysis for somebody that's severely acidotic would be the treatment. W stands for water removal. So if the kidney cannot remove water from our body, you're going to look for signs of fluid overload in your patient. So look for those crackles and tachypnea and tachycardia, shortness of breath, pink, frothy sputum. Remember, frothy sputum means pulmonary edema. They'll have a low O2 sat. They may have anasarca, which is all over edema, and feelings of impending doom due to the hypoxemia caused by the pulmonary edema and vein distension. So you might see like JVD. All right, so your nursing interventions, get that head of the bed up first, high Fowlers, put O2, furosemide if the patient is still making urine. If the patient is no longer making urine, there's a point in chronic kidney disease that the patient is going to stop making urine. So furosemide is not going to work on somebody that has that far along in their kidney disease. So they may need dialysis if they have fluid overload. All right, some drugs. Morphine is a very good drug for pulmonary edema. Aminophylline, we don't really give that anymore, but it was a good drug. Digitalis. Dig helps the heart contract stronger, so it helps with getting fluid off the lungs. And then diuretics, oxygen, blood gases, and fluid restriction. Okay, that's going to be the treatment for that. The fluid restriction for somebody with kidney disease is to take the 24-hour output and add 500 or 600 mLs, and that's going to be the input they can have the next day. So, for example, if my patient puts out 1,000 milliliters today, tomorrow his intake can be 1,500 to 1,600 mLs. That's how you figure out fluid restriction in kidney disease. E is for erythropoiesis. So our kidney, the erythropoiesis that works in our kidney makes red blood cells. So if our kidney can no longer do that, your patient is going to be anemic, and they're going to need epigen or epoetin alpha. So make sure anybody that is taking epigen alpha or epoetin alpha, I should say, you're going to monitor for headaches, hypertension, seizures, DVT, and MI. Because when they start making the blood cells, the blood is going to get thick and viscous. And remember, they're on a fluid restriction to boot, so that's why their blood vessels could get clogged and they could suffer from DVT and MI. It also needs to be refrigerated. T is for toxin removal. So the kidney helps remove medications from our body. So somebody that has kidney disease and cannot remove medications may become toxic for those medications. So look for adverse effects, amplified adverse effects, I should say. They may have a high BUN and creatinine, which leads to uremia, and they're going to have a low glomerular filtration rate. So monitor for signs and symptoms of uremia, and I'm going to go over that like at the bottom in a separate thing because it affects every body system. Uremia does. And they're going to need to have a low protein diet to prevent uremia, because when you eat protein, it converts into urea and then ammonia if the body can't break it down. Okay, so they could get in uremia, they can get confused. All right, blood pressure control. If the kidney can no longer control our blood pressure, then they're going to have hypertension. So they'll need, they can be treated with ACE inhibitors, calcium channel blockers, and beta blockers. And remember, ACE inhibitors and ARBs can increase potassium. And that's important because the kidney can also cannot get rid of potassium. So you have to watch out for a high potassium in patients with kidney disease. So E stands for electrolyte balance, and I kind of already touched on high potassium. So if your kidneys aren't working, you're going to have high potassium, which can lead to dysrhythmias and death. You're going to have a high phosphorus level and a low calcium level, and this can lead to osteodystrophy. So people with, like, for example, chronic kidney disease have osteodystrophy, and they can get like pathological fractures. It's really easy for them to get injured and fracture bones. High magnesium and high sodium. All right, for the high potassium, remember kind. So Kxalate, insulin, and dextrose. And if you had to decrease a potassium quickly, you would use the insulin and dextrose. Sodium bicarb, no salt substitutes because of the high K. And dialysis or diuretics. So they would get diuretics if they're still producing urine. And if not, they're going to need dialysis. For the high phosphorus, patients with kidney disease should avoid high phosphorus foods like dairy, soda, nuts, and meat. And they take phosphate binders with all meals. So C-vilamer or aluminum-based antacids. All right, low calcium. Encourage calcium in the diet, and they may need to take vitamin D as well because, oh yeah, it's my last one. The kidney does help with vitamin D activation. So if somebody kidney can't do this, they'll have low calcium. Okay. They need to avoid magnesium containing antacids because they cannot get rid of the magnesium. So these are the conditions that you're going to find a wet bed findings that I talked about. So that's the oliguric stage of acute kidney injury, the oliguric stage of acute glomerulonephritis, chronic kidney disease, chronic pyelonephritis and glomerulonephritis, and polycystic kidney disease. So all these diseases are going to suffer from a wet bed, okay? So just remember that. Now, this is uremia. I mentioned before it touches every body part. So ammonia is neurotoxic. So patients that have uremia are going to have something called asteristics, which is wrist flapping. They are also going to have lethargy. They're going to be tired, but they're going to have confusion and coma, and they could have seizures. Okay? Ammonia, the uremia, is also toxic to mucous membranes and serous membranes. So they can get like pericarditis. They can get pericarditis, and also they can have like mucous membranes, like ulcers on their mucous membranes. And they could end up, I told you about heart failure, and that's because of edema. Renal osteodystrophy I talked about, so they're going to be at risk for bone fractures. And then vomiting, anorexia, and nausea. Okay, so uremia really upsets the GI tract. People with uremia have this color. It's like a yellow, tan, gray color. It's called sallow, S-A-L-L-O-W, sallow, a sallow color. And it can almost look kind of tan too. So that's what the pigmentation in their skin is going to be like. Uremia makes them extremely itchy, okay? And uremia makes the platelets not work as well as they should. So although the patient may have normal platelet levels, they're going to be at risk for bleeding because the platelets don't work well. All right, so those are signs and symptoms of uremia. All right, for acute kidney injury. Acute kidney injury, something insults the kidney, some kind of low blood pressure, some meds that are nephrotoxic, and I'll talk about that. So something triggers the kidney and it has an acute kidney injury. So something injures the kidney and there's rapid loss of renal function, which results in a high BUN and creatinine. High BUN creatinine is going to turn into uremia, so we need to watch that. So there's 3 types of causes of acute kidney injury. And the first type is called pre-renal. And this is most types of kidney injury are due to pre-renal causes. So it means the kidney is not perfusing. So this could happen like in shock. It could happen in dehydration, diarrhea, diuretics. So those are the 3 Ds, diuretics, diarrhea, dehydration, shock, and vascular reasons, so hypotension. Okay. Now, intrarenal causes of acute kidney injury, think about medications and connective tissue diseases. Okay, so nephrotoxic medications such as cisplatin, the vancomycins, the gentamicins, and then diseases such as lupus and scleroderma. Those are connective tissue diseases which can result in kidney disease. And then contrast dye, that, and hold the metformin 24 hours before and 48 hours after a test. Diabetes and hypertension. Okay, those are things that cause intrarenal acute kidney injuries. And then with post-renal, this means there's some kind of an obstruction in the urinary system, so like renal calculi or BPH that we talked about, benign prostatic hypertrophy. And then after somebody has a TURP, if they have an obstruction from blood clots, this can result in a post-renal acute kidney injury. So there's 4 phases of acute kidney injury. It's the onset, meaning the whatever caused the injury to happen. The oliguric phase, the patient doesn't put out urine. So the definition of oliguria is 400 mL of urine output in 24 hours. Okay. Or sometimes this is called the anuric stage. Anuria, the definition of that is 100 mL of urine per 24 hours. Okay. Diuresis, that stage happens in 2 to 6 weeks, and that signals that the kidneys are starting to heal themselves. Recovery can take up to 1 year. Okay. So, and 10% of the people who sustain an acute kidney injury end up with chronic kidney disease. And usually it's older adults, and we need to do better at this, okay? We need to be able to recognize who's at risk so we can stop this from happening. So the signs and symptoms of the oliguric stage in the treatment, just see your wet bed in uremia, okay? So does that make sense, though, that the patient is not putting out urine, so they're going to have the same signs and symptoms in treatment as somebody with chronic kidney disease, okay? Because they're not making urine. Now, hopefully, in a few weeks, they're going to start diuresing. So in the diuretic phase, they're going to have a huge amount of urine output. They could put out like 10 liters a day. So you have to stay up with the fluids, replace the fluids, monitor the potassium, because now in the oliguric stage, you worried about high potassium. Now you have to worry about low potassium. Okay, monitor for dehydration. The BUN and creatinine are going to start returning to normal. The glomerular filtration rate, the normal glomerular filtration rate is about 120 to 125 mLs per minute. So that will start going back up again after the kidneys start healing, and then recovery. So again, I said 10% of patients will never recover. So we got to do better identifying who has it. Okay, so with chronic kidney disease, the most common cause of chronic kidney disease is hypertension and diabetes. Chronic kidney disease is going to affect every body system, all body systems, whereas acute kidney injury can affect most body systems. So look at your wet bed and uremia for signs and symptoms in treatment of chronic kidney disease. Now, there are 5 stages in chronic kidney disease, and you don't have to know the creatinine level and stuff like that, okay, in each stage. But this is what I do want you to know. As the patient progresses through the stages, okay, the kidney function gets less and less and less, okay? So that means by the time they get to stage 3 is when they have to start following, the low potassium diet. They have to stop, the low phosphorus diet, take the phosphate binders, be on the fluid restriction, okay? Stage 4, the patient has 3 choices. They can either choose to do dialysis, get put on the transplant list, or death. Okay, and the reason you have to do it in stage 4 is you have to start planning and doing some teaching before stage 5. Stage 5 is end stage renal disease, and this is equivalent to chronic kidney disease, stage 5. Okay, so again, some of the signs and symptoms. Whoops. Okay, the symptoms that are colored brown, this is due to uremia, okay? The blue is due to cardiovascular changes. Okay, so those are the 2 colors I have. Okay, so again, neurologically, you may see asteristics, which is flapping of the wrists. The patient's going to be tired. They'll have ataxia, and they could end up with encephalopathy. Just like diabetics get retinopathy, people with kidney disease may get it too. Cardiovascular wise, usually it's in people with hypertension, but it can also make the blood pressure even higher. Heart failure and CAD you're going to look for. Pericarditis can happen due to the uremia. Vomiting, anorexia, nausea, GI bleeding, stomatitis, gastritis, and fetor. Fetor is really bad breath. That can all happen due to uremia. They're going to have hyperparathyroidism. They're going to have amenorrhea and erectile dysfunction. And then they'll have anemia, bleeding, and infection. And this is all due to uremia. For pulmonary, they'll have pleuritis, pneumonia. They can have that. Pulmonary edema. We talked about the tachypnea and Kussmaul breathing due to the metabolic acidosis. In the skin, they're going to be itchy. They'll have that sallow, yellow, tan, gray color. They may have purpura. They may have petechiae, tinted skin because of dehydration. If they're on like a fluid restriction and uremic fast, okay? They'll have peripheral neuropathy. So just like diabetics, you have to be very careful with their feet. And then the labs, again, high potassium, high phosphorus, high magnesium, low calcium, low pH, low bicarb. And this is the venous bicarb, not the arterial gas bicarb, okay? So those are the things you're going to look for. Increased BUN and creatinine and low GFR, decreased GFR. Okay. I'm going to talk about hemodialysis and peritoneal dialysis because patients, when they're in stage 4, you usually need to choose between one or two of these, even if they're going to have a transplant, because they may need to get on the transplant list, and there's a lot of planning involved with that. So this is a vascular access device that you can see right here in A, okay? So with the vascular access device, nobody touches this but the dialysis nurse. This is not used to give your IV medications. It's not used for IV fluid. It's only used for dialysis, and that's to decrease the chance of infection, okay? So no fluids through the line. You can't do critical care monitoring through the line, and you don't draw blood through that line, okay? It's only for the dialysis nurse to touch. And then the nursing implications for hemodialysis. So somebody could sustain one of these for a very long time, and use this as their vascular access device for dialysis. Okay, before hemodialysis, you weigh your patient, and then you weigh it after. You need to know the dry weight. The dry weight is the weight after. Patients who have dialysis are going to be at risk for bleeding 4 to 6 hours. So they should not have any procedures after dialysis to prevent them from bleeding out. So make sure you have protamine sulfate on hand, because that's the antidote for heparin. When I worked in a cath lab, it was like in rural West Virginia, so I had to like have a lot of trades. So we did cardiac casts, but we also did like VAS casts for patients with end-stage renal disease, but they get clotted a lot, and they would come in and we'd have to like try to declot them, or we would like replace it, but we get like a lot of heparin. But one of the first things I always did, because protamine sulfate isn't used that much, I would come in and check on the expiration dates on my protamine sulfate, and also make sure I had it handy so it was ready, because you give so much heparin. All right, monitor the vital signs after hemodialysis. Hypotension is very common. There's something called disequilibrium syndrome that they can have, and this is due to having the dialysis be run too quickly. It can cause confusion and cerebral edema. They may need phenytonin, which is, you know what phenytonin is. Prevent and treat by slowing the infusion if they get this, okay? So that's one of the things the nurse might do. They might become hypotensive. So what you would do is put the bed flat, and they may need a little bit of fluid. Anemia. So the hemoglobin is going to go down after hemodialysis. That's normal. And remember, they already probably have anemia, so this is just a little bit more. So with the epoetin alpha, it has to go in the refrigerator. Hold for a hemoglobin greater than 11, a headache, or high blood pressure. Now, with air embolism, hemodialysis is one of the procedures that can cause an air embolism, okay? And people can die for this, so pay attention. So, air embolism is air in the arterial system that goes to the lungs, right? So the patient, you can remember the mnemonic catfish for cough, chest pain, arrest, and sudden death. T is for tachycardia. F is for low grade fever and diaphoresis. I is for increased anxiety, so that means those feelings of impending doom. S is for SOB and syncope, so they'll be lightheaded and hypertension. So if you suspect your patient has this, stop what you're doing, put them on the left side in Trendelenburg, and that will make the bubble go up to the right atrium. So hopefully it won't harm them. Do a rapid and put some oxygen on your patient. Okay, now patients can get AV fistulas or graft. I mean, if they have chronic kidney disease, what they do with the fistula is they connect a vein to an artery, and it matures over weeks. And then with a graft, this is like a silicone graft they would put in and they would connect a vein to an artery. So when I worked in PACU, we had a lot of these patients that came in and had these done. Okay, so the grafts can usually be used immediately. The AV fistulas take a long time to mature, but they work well for patients. Okay, so if somebody has one of these devices, no IVs, no BPs in the arm with the device, okay? So that's important. Now you're going to palpate for a thrill on an AV fistula. You're going to also take your stethoscope and auscultate for a bruit, and that lets you know that the AV fistula is patent. Okay, so that's something you're going to be looking for. Do your neurovascular checks. So check for pain, pins and needles, pulse, parlor. You want to know if it's cool. So you're going to have to do that frequently. And then encourage range of motion of that arm. You don't want the arm just stagnant. They shouldn't sleep on the graft or the fistula site. They shouldn't wear a watch on that side. And don't carry heavy items. They need to keep the area clean with chlorhexidine. And this is just a big gnarly one. Sometimes if they've had them for a long time, they can get big like this. And then sometimes even some patients might have had 3 or 4 in their lifetime, and you'll see them they'll do them on one arm at first. It's quite interesting. All right, so just check for slow cap refill, diminished pulses, pain, or parlor. That's what you want to look for. Okay, now we're going to go into like peritoneal dialysis. Like one of the benefits of peritoneal dialysis is it allows a little more freedom, because if somebody's on hemodialysis, they have to really plan a lot, okay? It's like a full-time job. They have to go 3 or 4 times a week for 3 or 4 hours at a time, okay? Now, so peritoneal dialysis is contraindicated in anybody with intestinal adhesions or anybody with polycystic kidney disease. And that should make sense, right? Because they have like damaged kidneys in their abdomen. So you wouldn't want to be putting fluid in there and popping all these cysts on the polycystic kidney disease. So the good candidates for PD are people who have the cognitive ability to do the PD by themselves, because usually it's at home. Older adults who can't tolerate taking a lot of anticoagulants are also good candidates. So peritoneal dialysis, they get a catheter that's put into their abdomen, and it goes into the peritoneum. And so peritoneal dialysis includes one PD exchange is a fill and a dwell. So if you fill the abdomen, it dwells in the abdomen. The provider orders like how long for it to dwell, and then you're going to drain it. So you're going to fill 1 to 2 liters over 20 minutes. Now, when you first start doing it, they have to do it graduated, because it takes a while for the peritoneum to like stretch out. So, they would work up to 1 liter, then maybe to 2. You wouldn't, on the first time, put a whole 2 liters in somebody's peritoneum, because they're going to get respiratory distress. And that is a known side effect of peritoneal dialysis. So you do need to watch out for that, okay? So when you drain, okay, you got to keep track of what went in, okay, because you want to drain that out. So when you drain it out, that's called the drainage is called the effluent or the outflow, and it drains by gravity into a collection bag. So if you're getting less output, make sure you're moving the patient like from side to side so it will drain. So your complications of peritoneal dialysis. So one of the benefits of both hemodialysis and peritoneal dialysis is once patients go on dialysis, they're able to eat more protein. And that's because they lose protein during dialysis. So like the people that are on peritoneal dialysis, there's a bigger protein loss in peritoneal dialysis, and they don't have to worry about potassium in peritoneal dialysis. So that's another thing that's usually a draw to peritoneal dialysis. Okay, now because there's sugar in the drain or in the peritoneal dialysis, they can suffer from hyperglycemia. They can get peritonitis. So peritonitis is an infection of the peritoneum. You're going to look for a fever, like fever, tachycardia, hypotension, in a board-like abdomen. That is the telltale sign that somebody has peritonitis. So rigid abdomen, board-like, hard. That's kind of what you'll hear it described as. Patients can perforate their bowel when doing this, so they have to be careful. They can gain weight. They can have tunnel infections. Here's a catheter in somebody's belly, so they can get that. The diacylate can leak around the tube. So your interventions for outflow, okay? The outflow, you want to make sure this outflow bag is in a good position. It needs to be dependent. Like think of a Foley bag. You need to drain it, okay? So it needs to be dependent. Check for kinks. Roll the patient side to side. Make sure they maintain good body alignment when you're doing this, and turn them side to side. You also want to know if the patient is constipated, because this could be a reason they're not draining well. So they're going to have to increase fluid and fibers within their range, right? Okay, so the benefits. It's a short training program. It's easy. Patients can travel, and they can continue to work and have a flexible schedule. Fewer dietary restrictions. Remember, they can have a little more potassium, and they can have a little more protein. The cons, they're still going to need phosphate binders. They cannot have salt substitute, although the K restrictions are more liberal. They could end up with hyperlipidemia if they don't already have it. It can go higher. It takes more time to complete. So although hemodialysis is 3 times a week at 3 hours at a time, this peritoneal dialysis can be daily and take 12 hours to finish, okay, top to bottom. Peritonitis is the most serious infection they can get. So the first sign is going to be cloudy effluent. So that's when they're draining, okay? Antibiotics could be added to the diacylate. Peritoneal dialysis requires strict sterile technique, whereas hemodialysis does not require strict sterile technique, and that kind of surprised me. You got to wash your hands and watch out for peritonitis, the board-like abdomen. All right, so that does it for our kidney section.